So, since we have the orthopedicians as well with us, if I'm not wrong, and this is the topic which we both as both the departments, the as well as the radiation oncologists, they also see it combinedly. So, osteoporosis in cancer patients, bone density decreases with age. These are the few comments which I have stated upfront. Uh, Aromatase inhibitors and androgen deprivation therapies are associated with increased risk of osteoporosis. Tamoxifen is somewhat protective. Treatment induced bone loss can be managed with exercise, calcium, vitamin D, and adjunct therapies, as was shown in the previous speaker's talk. Aromatase inhibitors induced disease decrease in bone density reverses after treatment termination. So, do you agree with these points, and do you want to add on to something, Dr. Ashish?
I think you have summarized it, the crux of the matter. That it's a very common problem actually that we encounter in everyday practice, and particularly patients who are elderly at higher risk of these complications, and one needs to be very careful and monitor these patients.
So, with tamoxifen being somewhat protective, like of course in postmenopausal it is protective, but in premenopausal situations where we are introducing tamoxifen, it is a anti-estrogen. Eventually, does affect the bone health. Do you agree with that part? That it has a sort of mixed response again on the bone health. It's not just entirely protective.
So I think usually in premenopausal women, it is not so much of an issue. There would be some impact of the maybe chemotherapy that the patient is receiving in terms of decrease in bone mineral density, but I don't think so. It's really clinically significant.
Quite right.
If you are combining this with GnRH analogs over in suppression, then probably the losses would be even more.
Okay, so we move on to the case that we have. This is what we are practicing now, switching gears towards more of a GnRH agonist in the era of post soft and text data. So this is a 38-year-old lady who is diagnosed with breast cancer. It's a T2N1 disease status post surgery, ERPR positive, and she has received adjuvant chemotherapy, and now she's on LHRS agonist and exemestane. So the risk of osteoporosis, like it was as stated in the soft and text data, it's nearly around 42% of patients having osteoporosis, and nearly 7% were having fractures. Does that worry you, Dr. Biswajit? Or
Yep. So, in our practice, what we do is we do a BMD for all patients. If they are on aromatase inhibitors, whether it's premenopausal or postmenopausal, and we give bisphosphonates every 6 months, irrespective of whether the BMD is osteoporosis, osteopenia, or normal. So, all patients we give them 6 monthly bisphosphonates along with calcium and vitamin D.
so my question is that, and since you have directly come to that point, would you start bisphosphonates straight away in a 38-year-old upfront, irrespective of what the BMD is?
If you are using aromatase inhibitors and you have GnRH analog, as you showed the data, you have almost 40% of patients who are going to become osteoporotic. It's better that we prophylactically start them on the bisphosphonates. And also there is some data to say that some DFS benefit is also there in postmenopausal mainly. The premenopausal, it's not very clear.
Do all my panelists agree with the comment that we should start upfront, or do we, yeah, please go ahead, sir.
I think we should base our decision on the DEXA score. If it is too bad, we need to start upfront.
At 38, premenopausal lady, DEXA score would be in positive rather. So
it's probably keep her on follow-up, yearly DEXAs, and then act if it is dropping fast. But exemestane plus Docetaxel would mean a fast deterioration in the BMD anyway.
Dr. Asim, sir.
exactly if the ovarian suppression has been done, then later on it will be bone mineral density will be low.
Will be
So
low,
will
but
be
now
low.
it is not low. As for now, it is not low.
Yeah, that is fine, but preventive step doesn't cost you much. First of all, and it's there is no great harm of giving this anti-resorptive therapy also, and 6 months is quite fine. So I would go for this 6 monthly interval giving this zoledronic acid and all. And the other thing is resistance exercises are important. If you are not planning to give this resorptive therapy, then we can teach them to be exercise and all that. But most of the time we ignore exercise and we are saying like walking and all that is good. That is fine. But resistance exercise is something different, where you have to challenge your muscles and all that. So that may cause the improve the mineral density and the better absorption of the calcium and all that. That we can have.
You also agree with that point?
No, I do not agree with that actually. I feel that if the bone mineral density, DEXA scan is showing a BMD DEXA score is more than 2, then probably in those patients I would consider. I think we underplay the role of exercise, and exercise has a lot of benefits, both in terms of preserving the bone health, the psychological health of the patient also. So we should, I feel in such patients we should focus more on exercise and vitamin D, and only if the T score is more than 2, then I would consider adding prophylactic bisphosphonates.
But the exercise data just presented now did not actually show any benefit. The high dose vitamin D and exercise.
So I think so. At least all of us are agreeing that baseline DEXA scan is at least important. We might not be on the common platform that we would start on with a prophylactic bisphosphonate straight away. Dr. Mish, you have a point?
Yeah, just wanted to ask how many of the people who are practicing medical oncology has seen actually a fracture in a 38-year-old lady who's about to start GnRH analog in clinical practice? Forget about the
I have
abstracts.
never seen.
So, but one thing is we miss out many microfractures which we will generally not pick up.
Clinically significant
And,
fractures.
yes, agreed. But your lot of pains which we most of the times say that it is because of because of the drug, might be we are not evaluating them, and maybe that we are missing microfractures which
Normal DEXA scan with
No.
absence of clinically relevant fractures.
So
in
what
our
Dr.
practice.
Amish is trying to say, sir, Dr. Biswajit sir, is that it's just the starting of the aromatase inhibitor therapy. You just have not exposed the patient yet. The patient is going to be started. Would you start at that point of time the bisphosphonate right away, or would you wait for a year down the line for the BMD?
say the
to
data
deteriorate?
shows that 40% of them are anyway going to develop.
Yeah.
So why would you wait and not give prophylactically?
Okay, so if this figure could convince you, Dr. Biswajit sir and Dr. Asim, I mean, if you look at the score, BMD scores in such a age group, these are in the positives actually. This is not in a negative. And then eventually with the onset of menopause, which would take time, there is a decrement, but then there is a gradual decrement. Over time, yes, the risk of fracture, once the BMD score decreases below minus 1.5, then the risk of fractures really increase in a logarithmic or a very steep manner.
So I guess this is for the normal women and physiological this graph, but we have given the goserelin, and which is a very potent suppressant of the ovarian function. So we might not wait for the event to happen.
So I'm coming to
and
that.
Osteoporosis is not an event which will be picked up in the fracture
Yeah.
and all that. So it is a very slow going process. Once a while we do the BMD and all that, we don't do. So in that context, I was saying like if we are offering them, it's not a big deal. No
So
harm.
this happened to be Dr. Bakshi's patient, and therefore this patient was not given bone modifying agents, and
Actually,
her baseline
most
scan.
of the center they don't have in-house BMD facilities.
Yeah.
This is the biggest
So
problem.
her baseline scan showed a T score of minus 1.1. However, after 1 year, now it is showing osteopenia, and the T score now is minus 2. But she is also symptomatic for joint pains. Now, of course, I mean that part of the panel is already for starting upfront bisphosphonates. Dr. Ashish, would you now consider bisphosphonate therapy, or would you still wait?
So I would still wait. The bone pain that you are talking about, joint pain, could be due to just exemestane also. So I would again focus on exercise because exercise has been shown to reduce the incidence of joint pains and arthralgia in patients who are on aromatase inhibitors. So I would not still initiate.
So you wouldn't still initiate. I am saying that this is his patient only, so you know. So this patient also was not actually initiated. Okay, so that slide is later. So we see that in this graph, definitely there is a steep dip in the percentage of BMD patients on GnRH agonists as well as on aromatase inhibitors combined. Of course, tamoxifen being protective over there. So just the T-score, does the only T-score matter? Like osteopenia, -2, would you not consider adding bisphosphonates if there is a family history of fracture, or if there has been if this patient also has rheumatoid arthritis?
So I think that point is well taken. So when we are assessing the patient, we would look at the comorbidities of the patient, the concurrent medications that are going on, previous steroid exposure as you have mentioned here. So all those things one has to look at and then accordingly kind of take a call. So I would individualize that treatment. But as a general thing, we would not. But yes, of course, if some high risk factors are there which kind of predispose the patient to a more likelihood of developing fracture, then I would.
So may I ask the panel, how many of us are using this sort of score, the FRAX score, which also interestingly has element of parental history of hip fracture. So how many of us are looking into these sort of variables while taking the decisions when seeing a T-score of between -1.5 and 2.5?
The BMD, when you do the bone mineral density, actually the machine itself gives you the FRAX score, and it predicts the 10-year incidence of risk of fracture. So it's definitely a useful score, and we should look at it and just not look at only the T-score.
So I think in terms of Indian, again, can you just go back?
Yeah.
In terms of Indian patient, if you look that like if you are applying this to a woman who is on aromatase inhibitors, the current smoking or alcohol intake are not very common in Indian population. Of course, in the cities, probably these things are increasing now. So probably we will see more and more of these patients who are going to get predisposed.
But secondary causes of osteoporosis could be there, hypothyroidism or let's say rheumatoid arthritis. They could still be there.
Absolutely. So even patients who are on concurrent steroids, there are a lot of patients who are on concurrent steroids. So those are the patients who definitely one has to kind of consider them for business.
So in continuation of my question, is it good enough for patients on aromatase inhibitors and cancer therapy? When this has been a debate for FRAX score that FRAX score has not been evaluated majorly in cancer patients and especially in breast cancer patients. So do you think that the last point over there, secondary causes of osteoporosis, if you take that point for patients who are on aromatase inhibitors and they have some sort of arthritis, arthralgia, would that point be equivalent to rheumatoid arthritis and add on to your thing that you could consider adding bisphosphonate?
So I think if you look at the criteria, rheumatoid arthritis, organ transplantation, pulmonary disease, probably these are the patients who are often given steroids as a part of treatment for those complex conditions, and maybe their increased risk is in general anyway due to that. So I would still say that logically this is still applicable to our group of patients.
So you agreed with that. And I think so ESMO also in 2014 acknowledged that a lot of these points were actually taken from the FRAX score as well. And in the patients who had a T-score between -1.5, below -1.5 to 2.5 or 2, they were actually looking at these particular variables as well, and consideration of bisphosphonate got stronger if one of these factors were present along with a T-score below -1.5. So coming to our patient, and ESMO 2016 guidelines also did mention that for younger patients where they have been on OFS therapy and have been amenorrheic for more than 12 months, one can consider in a low BMD, one can consider prophylactic bisphosphonate. So when you talk about anti-resorptive therapies, especially in this particular patient, where do you find the data which would be robust, and which of the agent would you use? Yeah, any of you can take.
So in terms of adjuvant, if you ask, I think the data is only for zoledronic acid. Denosumab adjuvant data is not very convincing.
So denosumab, again, one more concern is that probably there is more resorption once you are stopping denosumab. Also, there is one concern that if you choose denosumab as an anti-resorptive therapy.
Should substitute zoledronic if we stop the denosumab surgery? Because the data shows that vertebral fractures increase if you stop the denosumab and do not.
Yes. So, as I said, that this was Dr. Bakshi's patient, and she was found to have hypovitaminosis D, and she was given supplements and was given advice to exercise daily. So, let's say this patient started on bisphosphonate or denosumab for osteopenia and other factors, let's say rheumatoid arthritis being there. So, how would you follow up this patient? How would you monitor this patient, see the bone health of this patient now? At what interval?
We do a scan every year, once a year.
Okay. So every year, and let's say the BMD, the T score was -2, and you get a -2 at another year. What do? Do you change the therapy? You're not satisfied with the therapy? You consider it as a therapy failure, or?
So once we start them on bisphosphonates, the number of patients who have a situation like this is very, very less. So in a situation where if we have such a situation, either one option is to change them to tamoxifen, but in a premenopausal, this lady, I would the benefit of giving the aromatase inhibitors is much higher than the chances of, the risk of developing a fracture. I would still continue, but the percentage is very, very less in whatever practice which we see once you start them on the bisphosphonates.
Okay.
So other thing is we should check their calcium intake also per daily basis. So it should be normal is 1000 mg to 1200 mg.
Okay.
But in that certain situations it should be higher than the 1200 mg. So that the store can be replenished and the score can be up.
So why I was trying to tease out this point was because as per the data on osteoporosis, if we have orthopedicians in the panel, in the house, do we have orthopedician? Okay, so in osteoporosis, probably the data says that you need to not get worried if in case that DEXA annually might not be really mandatory for patients on bisphosphonate once it has been started. So probably once in 2 years, you might take a call. The bone density might not change so rapidly or improve so rapidly. So, okay, switching gears towards a metastatic scenario. And here is a 70-year-old lady who was having back pains, and a PET CT over here, as you can see, is showing multiple skeletal metastasis, both in the axial and appendicular bones. So, since we do not have a orthopedic surgeon, but then when is it that you refer to your orthopedic surgeon? Do you use any scoring system, sir? We have one of the scoring systems in front though.
Yeah, I do not use a scoring system in my practice, but if the patient is having symptoms related to the bone pain, particularly in hip, then I personally evaluate them closely for presence of a fracture in the neck.
Okay.
We do sit with the radiologist, ask them about the weight bearing areas, whether it's significant or impending fractures.
So, just quickly moving on to the schedule of these particular therapies, and we had the Alliance trial showing that once in 3 months is as good when you are looking at SRE as the primary endpoint, and also now that you have some data for denosumab, zoledronic was already there, data on pamidronate also coming up in this ASCO, this particular paper, which was showing that 12 weekly might also be good enough for denosumab. So, and there is a big trial again going, reduced trial, which would add further data. So, thank you. Thank you to the panelists.
Thank you.